is that it led to too much over-testing at the high end, when we found a lot of plaque. So this is just for statin therapy. Now we've moved the bar down. I have a paper coming out, hopefully in the New England Journal of Medicine over the next couple months. It's still being decided on at the highest levels there, but we'll see. But we looked at that MESA study over a decade, and the best predictor of a high-risk patient was a score of 100. So the guidelines are going to shift towards 100 as a calcium score to start statins, not 300 or 400. So I think that's just a refinement of how to use the test. This, I think, is really important. This is what happened after they put these guidelines in place. I mean, what literally happened in the United Kingdom. This is socialized healthcare. They have good data on testing. And when they instituted heart scanning, costs went down. The mean cost of the investigation. Sorry. Weird. I'm touching it. The mean cost of investigations per patient on the right went down. These are in pounds, but you can see we're saving hundreds of dollars, hundreds of pounds per patient. And on the left, the mean number of investigations went down. So not only are we doing less tests after the scanning, but we're doing cheaper tests to follow them up. Again, a lot of people have zero, and it drives the costs down. So there's another proof in a countrywide assessment of the United Kingdom that shows that implementation of calcium scoring doesn't cost us money, but actually saves us money by less downstream testing. Now, it always goes back to the simple question, though, is that risk factors are free. I mean, I can literally talk to my patient, and for under $10, I can get their Framingham risk assessment. And a calcium score costs me $100. So does that really make sense? So we have these risk factors that are virtually free. Do you have a family history of heart disease? Have you smoked? Do you still smoke? What's your male or female? What's your blood pressure? And we can obtain a thing. And this is the most recent study. This was actually done in Northern California. This paper was just published recently. This is by Arana et al. And Jack. 307,000 people in Northern California were followed after risk assessment. And in red is what the expected event rates would be based on this new risk calculator, this ACC-HA risk calculator. And you can see if you're low risk based on the risk calculator, you had very few events. You were predicted to have 2.5% or lower risk, you had a 1% risk. 3, 4, 8. That's great, because that fit exactly with the risk calculator. The problem is, in blue, is what really happened. And what really happened was really what we would call gross overestimation of risk. No matter what risk category you choose, you were 4 times less likely to suffer an event than the risk calculator predicted. In other words, the risk calculator was wrong to the tune of 400% over prediction of risk across every one of these categories. You're supposed to have a risk of 8.7%. According to the risk calculator, less than 2% of patients actually had an event. This is an HMO population. That's great, right? I mean, so, they argue, the people who wrote the guidelines said, well, this was an exceptionally treated population, and I would agree that they were treated to a current standard, but it's not like this population was treated by only the stars of our preventive community, and every one of them had multiple executive physicals throughout these years to lower their event risk. This is what happens in the population. So the current risk calculators lead to gross over-treatment of patients. And even if you believe that statins should be in the water supply, it is more expensive, it's more expensive to put it in the water supply than it is to treat selectively. I'll show you a couple papers. This is terrible performance. This is the worst risk predictor in the history of risk prediction. This new pooled risk cohort. I can tell you that from the ACC and HA levels, they're already going to move away from this pooled risk equation because it performs so poorly in the population. So if we can't risk assess and use a simple free risk calculator to determine our patient's risk, then maybe we do need some help in the trenches as we're seeing our patients.
So Matt,
Yep.
do you think that their training set to get this risk prediction score was a biased selection in order to get that, because it obviously doesn't reflect reality, and something had to be up
Right.
with how they created that score.
So yeah, and I think that's exactly the point. I think they created the score from existing cohorts of patients that did not reflect contemporary real-world treatment. And the validation cohort, they didn't develop it in MESA. MESA is our real-world, multi-ethnic population that's being done right now. They use older cohorts to create this. And then they tested it in MESA and said, well, it's not great, but it works well enough, let's go ahead and publish this. And I think instead of creating it in a current cohort like MESA and then testing it against the older cohorts, this is the same problem that Framingham doesn't work as well anymore. Back in the day, when we only had white males who smoked, it was a very good predictor of events, but our demographics of our nation have moved away from Framingham, Massachusetts, and it's just not as good a risk predictor anymore. We don't smoke at the same levels. We clearly have a multi-ethnic population. So this is their conclusion. This is from Rana. In a large contemporary real-world population, the risk equation substantially overestimated the actual 5-year risk in adults. Overall and across socio-demographic subgroups. No matter how you slice this 300,000 persons, it performed terribly. I mean, literally, it was not like just, it was biased by low socioeconomic status, or it was biased against by people of graduated college. This was every subgroup, every racial, ethnic, and gender subgroup they looked at was terrible. So can we fix that? Well, here's something that predated that. This is from Dr. Greenland and Pletcher from Northwestern. They did a paper, and they just looked at if we just treated calcium scores greater than 0. So we said, okay, we're going to eliminate half the people who have 0 scores and treat the half of the population that has any plaque, which I still think is over-treatment. Or we treat the population, everybody. Costs go, treating all. To prevent one event costs us $78,000. This is generic statins, $78,000 to prevent one event. $80,000 to prevent one event in men, down to about $18,000 or $19,000 to prevent an event. Clearly a win, since that event costs a whole lot more than $18,000 or $19,000. An MI, bypass, or death is a more expensive. But I think this still leads to overtreatment, because I would advocate treat over a score of 100, not over 10, so over 0. So this was a conservative approach. They then did another study. This was done by a different group, done by the Hopkins group. I was a co-author on this, but they looked at very conservative, this is right from the paper, using conservative parameters. We find that calcium score testing in intermediate risk patients is likely to be cost savings and more effective than both treat-all or the ATP3-based strategies over both a 5-year or 10-year horizon, whichever one you prefer as a epidemiologist, whether you want to look at the 5-year event rates, the shorter term, or the 10-year longer term events. Calcium scoring may enable providers to provide better risk-based treatment decisions in intermediate risk patients and enhance providers' ability to implement CVD prevention guidelines. In other words, concentrate on those patients who need attention and work less on some of those people who are the worried well, as we call them. So, can calcium scoring improve our compliance? Well, this is one study of population. 47% of the population had a score of 0, as I mentioned. Half the people had no plaque. To prevent one event, you would have to treat 549 people. This is based on actual event rates in MESA. You'd have to treat 550 people to prevent one event. If we just raise the bar to a calcium score of 100, we have to treat 24 to prevent one event. So we treat 25% of the population, and we have a number needed to treat that's dramatically better. More efficient use of healthcare resources. We've done a lot of studies on adherence. Very interesting to me as a preventive cardiologist, my patients have no symptoms. The adage is you cannot make an asymptomatic person feel better, but I promise you statins can make them feel worse. So I don't care how much of a believer you are, I'm a big believer in statins, they work. But not everybody feels great, and certainly they don't feel better than when they started. Pfizer came out with a combination product, they made Lipitor, They made and they came out with a combination product of a blood pressure pill and a cholesterol pill. At that time, they had a different medicine. I said, instead of combining a blood pressure pill and a cholesterol pill, doctors aren't going to be interested in that. Combine your atorvastatin with Viagra, and you'll get much better results. And I promise you, everybody who has impotence needs a little bit of a statin, right? So that would have been a better combo pill, and we came up with all cute names of what it would be called, but they never followed my advice. And their other pill fell by the wayside. Catalyt never made it. But anyway, it improves adherence. It gets people to do things. This is 4-year follow-up data, separate study from Eisner, but shows the same thing. Much more likely to initiate aspirin, much more likely to change their diet, much more likely to increase their cardiovascular fitness, going from non-exercising to exercising. Alan Taylor showed 6-year data, 7 times more likely to be on an aspirin and a statin if you have a positive calcium score. 7 times more likely to actually take the pills that we prescribe them with a simple test. So it delivers efficiency of healthcare. And we only focus our attention on the 25% who are really going to have an event over the next 5 to 10 years. So I'll conclude with this concept, that with better risk stratification, with a simple heart scan, a mammogram of the heart, we can match risk. How much risk is that person at with intensity of therapy? And we can do a lot. We have a lot in preventive cardiology to prevent a heart attack. But I can't treat everybody I meet, because most of them are not going to buy into it, and they're not going to actually take the pill. I can write a lot of scripts, but compliance is terrible. 50% or more will have 0 scores. So we know we can do better than that. And current guidelines overtreat at least 50%. The newest study from Rana says they overtreat 80% of patients. So we don't want to do that. And it improves compliance. We know that asymptomatic people will be more likely to stay on a therapy if I can show them that they have something in their heart that's causing a problem. So we're going to skip this and just finish with this. This is where we are in California. This is where calcium scoring is approved, at least in Medicare. Quantitative evaluation of coronary calcium to be used as a triage tool for lipid-lowering therapy in patients with intermediate to high Framingham risk. And that's where it's going to help us the most, in the intermediate risk population. So this is our current limited coverage decision by our California Medicare providers. We'll skip this and just finish with this one simple concept. This goes back 5,000 years. I'll read the English instead of the Chinese, but this was in the first Chinese medical text. Superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident, and inferior doctors treat the full-blown disease. And coronary calcium will give us that subclinical, that preclinical plaque to get us to go from inferior doctors waiting for the heart attack with our stents and our CCU to mediocre doctors. And maybe someday, in the eyes of the ancient Chinese, we can become superior doctors by preventing atherosclerosis altogether, but we're not quite there yet. So thank you all very much for your attention.
For patients that have low risk scores under Framingham, because those normal risk factors only explain about 50% of the coronary disease. Is that correct?
That's correct. 50, 60%.
So then, if you say, well, we have all of these people that have low Framingham scores, but still could have the problem, how do you define the group to test? Is it a family history? What's the biggest thing to get into that group, because you really want to address those people as well?
Right, yes, that's a great question, and I think that we're still trying to figure that out. From the population-based studies, it's still most efficient to take people with at least a risk factor, a known risk factor. We're going to miss a few patients who have no risk factors whatsoever, and the SHAPE guidelines, which I skipped for the sake of time, says instead of doing risk assessment, we should do a heart scan first, and if the heart scan shows you have plaque, then we can start treating what we can treat, but we know you have the disease regardless of risk factors. But it's more efficient for healthcare to take the people with at least a risk factor and focus on that group for testing. Because we know what the number needed to test to be, I don't want to have to test 100 people to find one person who then I could change their strategy on. So we still probably need a risk factor. Now, a risk factor could be men over 45 or women over 55. So it's not like we're saying you have to have over diabetes for 22 years before you would be considered, but you need something.
Do you have any data on the evolution of calcium score over time?
Yeah, so we've done a lot of work with that, and right now it's still probably not ready for prime time. In other words, that we have some good algorithms that show that if your calcium score is going up over 2 or 3 years, you're at increased risk. The people who are rapid progressors of plaque are more likely to have a future event. But we don't have all the treatment. So Dr. Marin, who I work with on this with Hattie, would say, I don't want a repeat heart scan because if I know they have plaque, it's not going to help me. I'm already going to treat them aggressively. It's not going to change my management. So we need to do a study of progressors and then add something to make them do better. And we don't know what that something is yet.
I'm just thinking the person is negative to begin with.
Oh yeah, so every 5 years, no sooner than 5 years. We would say absolutely, if your score is 0, you don't need another test for 5 years. So it's not an annual test like mammography because it doesn't develop that quickly. It takes years to develop. So 0 would be good for at least a 5-year warranty.
Dr. Zuniga?
Yeah, the United States Preventive Services Task Force last reviewed and published recommendation of in determined insufficient evidence in 2009.
Right.
All this information is newer. Do you know where they are in the cycle of reviewing this
Right,
information?
so it's
Yeah,
great
what's
point.
your reading of the tea leaves and what they're going to do?
So I have to say though, if I were on that committee, I totally would agree with them and I would give it an eye as well. What they said is, should every human being have a heart scan? And they said it's indeterminate, and nobody advocates that. So I don't think they even asked the right question, to be honest. But all of the papers I've shown you, every single study is dated 2010 or thereafter. They are reevaluating this, but not in the context of scan all, but rather, should we be taking these indeterminates and low intermediate risks and do a heart scan? And that's being evaluated by them. The data period is closed, and we do expect an answer, according to Dr. Kaplan, who was at the HRQ sometime in 2017. So it is being questioned. I would seriously look at the question they asked. And I would have also, as an advocate, I would have said no. I wouldn't advocate for the question. I think they asked the wrong question and got the right answer, that it's not yet ready. But I think that was just a tweak that we needed to make.
So for people who have been on statins for a long period of time, or
Right.
statins aspirin, how would you reevaluate them? If they go and have a scan, is that score going to be true, or when would you reevaluate them?
No, the score is true, and I see some people who come to me and say, yeah, I've been on statins for 3 or 4 years, I don't feel perfect, I think it's giving me this problem or that problem, do I really need to continue it? And we do a heart scan, and some of them are 0. And those patients, I say, you know what, I'm not a big advocate of withdrawing care, because I think statins are good overall, but I think in your case, we can stop it, wait 5 years and see what happens. Other people will have significant scores. I would say you need to double down on your statin. I saw a patient in the office on Thursday. They were on simvastatin 20, and they had a high score. I put them up to a atorvastatin 80. I think that's going to be a good event reduction for that person. So even though they're being treated, I changed their management by knowing the calcium score. And again, that's not the sweet spot of the test, but there are nuances where we use it in those capacities.
So, Matthew, in some case, maybe part of the question is, will you ever go to a 0 calcium score after you had a positive score?
Oh, yeah, no, you won't go from positive to 0. But some people on statins do have 0s because they never had a scan
Right,
in the first
and that's-
place. So I thought that was your question. Right.
No.
It can plateau, it stops going up. But calcification is probably the end stage of atherosclerosis, so it's probably more or less scar tissue. It's the tip of the iceberg. The more plaque you have and that's calcified, the more soft plaque you have as well. But it's never going to completely go away. We don't have liquid Drano yet. Somebody called it that there was a new drug that never made it to market. They called liquid Drano. We don't have that yet for the coronaries. Please.
Joyce?
So from just a general population screening, are you recommending the Framingham to be able to evaluate the risk rather than the?
So I think there'll be a new risk calculator. My colleagues are working on it. I'm not on that committee, but my colleagues are working on a new risk calculator to replace the 2013 pooled risk equation. And I don't know exactly what they'll come up with, but it'll hopefully be something that's a little more contemporary, that hopefully will work a little better in modern society, to not use the studies of cardia and 20-year-old trials to try to generate what would predict risk in 2015. So I think there will be a Framingham-like. Our risk calculator will be a little different, and right now, just because I want to play nice with my colleagues, I'm on one of the boards of the ACC. I still recommend until we have something new to use the ACCHA pooled risk equation. just because they're trying to push everybody to uniformity. And over time, uniformity is actually a good thing, even if it's not the optimal study. So I think we have a little work to do there. Please.
So I think you mentioned that the cost of this is about $100, which is equal to mammogram. One of the interesting challenges is now we're moving to 3D mammogram, which increases the cost a little bit because it's much more difficult, supposedly, by the professional side to review a mammogram finding. It takes a lot longer for the radiologist to actually look at a 3D mammogram. In terms of this, you know, the ability to really identify the calcium, it would seem to me, intuitively, I'm not a radiologist, that it's a lot easier and simpler to look for calcifications in coronary arteries than it is to look for abnormal findings, which are multiple in the mammogram. So is there a possibility that the cost could decrease as more sort of the test becomes, sometimes that does happen?
Sure. No, this test has gone dramatically down. If you were to shop around here in Sacramento, at Sacramento Heart used to do these heart scans, their standard price was $395 a scan. And even in that movie, which is now a couple of years dated, they quote $250. We're now down to $99. I think the price has dropped considerably. It is very easy to read. My techs who do the scan actually do the initial scoring, and I just kind of look at it quickly and say yes, or I rescore it. But it takes me sometimes seconds to sign off on a study, to be honest. So it is an easy test to do. It's much easier than three-dimensional anything, including mammography. I do three-dimensional coronary work, and that takes a lot longer to interpret. So, but I think the problem with it decreasing even further than $99 is only the equipment cost. The CT scanners are $1 million plus equipment, and that's the only thing keeping the price where it is now. But it's already come down fourfold from what it used to be, and I think it's in a pretty good place for most people to afford it. I tell them it's cheaper than a good meal. You say it's the cost of a good meal, but if you go to a good steakhouse, you're probably spending more than $100 by the time you're done. So for every 5 years, instead of having a steak, you have one scan. It's probably worth it.
And increasing your confidence.
That's right. If you have that steak, you're getting that score a little higher instead.
So as we segue to our next speaker, one question that I have, and if you all have other questions, please formulate them, is your recommendation on 45-year-old men as a mammogram for the heart. So you said one risk factor is age, and for men it's 45, and for women it's 55. And I wonder if you could just talk about that. We have the Pacific Business Group on Health in the room with us, and 45-year-old men tend to be, and women, tend to be your core executives.
Right, so I would say generally that would be the bottom starting point where you would start considering this. You could round it up to 50 or some other age, but that's the age of atherosclerosis, is men at age 45, women at age 55. That's our recognition by definition of risk. And of course, it wouldn't be everybody that age group. You don't think, oh my gosh, there's 150 million people who are in that demographic. That's not true, because you would cut it off based on risk. So the 45-year-old male who's diabetic doesn't need a heart scan because he already has diabetes and needs to be treated. The 72-year-old man who is over 45 years old doesn't need a heart scan because he already has a risk that would warrant statin therapy, probably based on having hypertension or other risk factors and their age. So I think you'd be looking at that as the minimum, and then you would target down the smaller group that actually has the right risk profile to warrant therapy. So it's not everybody in the US over 45. It's a narrow 45 to 60 with the right number of risk markers. Or women 55 to 70 with not too many other risk factors.
So everybody in this room knows me, and I, because I'm really, really proactive, had my scan done at, before age 55 and got some news that has me on a pretty strong statin. And I really, really appreciate this work. So thank you, Dr. Budoff.
One more question.
One more
I want to get on
question.
to our...
Just one last question, maybe. Since the evidence you're presenting is so compelling, I am wondering why it is not more commonly done.
It's the insurance problem. So when you tell a patient that this test is not covered by insurance, I mean, I'm not blaming anyone, I'm just telling you, when you tell a patient a test is not covered by insurance, they are less likely to want to pay money out of pocket. It's just a natural thing, and unfortunately, I think unfairly, but I'm biased because I've been doing the research, most of the insurance companies, not Medicare, not some of them, but some of the insurance companies call this test experimental. So when the patients call up and say, oh, that test is experimental, it sounds like I should be signing them for a consent form and paying them to undergo the test because it's an experiment. When in reality, there's been 1,000 published papers and all of this data. So I truly believe that it is being held back, at least by the label of being experimental. I would say if you're a healthcare provider, you don't want to pay for this test, then say, fine, we decided we don't want to pay for it. But to call something that's been around for 25 years and has over 1,000 published papers experimental, I don't think is very fair to those of us in the field, at least.
Well, and I think now the cost has come down, and the fact that you're saving because you're not treating everybody anymore, I think that they need to understand the additional literature over the last 5 or 6 years.
Yeah, and the literature's changed. Everything I showed you is the last 2 to 5 years. It's changed dramatically, and that's why the U.S. Preventive Task Force has taken up the question again, because it's all new now.
When will it come out, the US?
Hopefully 2017, but it's a government agency. I don't want to I don't want to predict too heavily exactly when it's due out, but I'm hopeful within the year. Thank you very much.